Hey guys, welcome back. We're going to continue our hematology discussion with another very important and a key area for SS exams, that is your myeloid neoplasms. When it comes to myeloid neoplasms, all you have to know is acute myeloid leukemia, myelodysplastic syndrome, and myeloproliferative neoplasms with a little bit of MDS, MPN overlap syndromes we'll discuss at the end of the section. But what I'm not going to discuss in this section is going to be the AML, acute myeloid leukemia, because I'm going to discuss AML elsewhere, probably in the acute leukemia chapter. Right now, we are going to concentrate on other aspects of myeloid neoplasms like MDS and MPNs predominantly, which is going to be the theme of this lecture. And before moving into the WHO classification of myeloid neoplasms, it's important that we understand the three important terminologies. Number one, myelodysplastic syndrome. Number two, myeloproliferative neoplasms. And number three, your acute myeloid leukemia. So for that, we need to start from the discussion on the pluripotent hematopoietic stem cell. You know, it's capable of differentiating into any lineage, including myeloid as well as lymphoid lineage. And with the help of certain factors, it gets committed to a particular lineage. Like it could be a myeloid lineage or a lymphoid lineage. Still, it is capable of differentiating into multiple different lineages in the same particular group. So once the committed stem cell under the influence of some growth factors again gets committed into a single lineage like erythroid, megakaryoid, or probably a granulocyte lineage, it's going to form certain precursor cells. You're going to have certain precursor cells are going to differentiate into certain precursor cells of that particular lineage, and these precursor cells ultimately again under the influence of certain growth factors form mature cells like erythrocytes, megakaryocytes, that is going to differentiate into platelets, and probably the various forms of WBCs. So this is the flow of what is going to happen in the bone marrow. In case if you're going to have an abnormal or a dysplastic maturation, so the maturation is abnormal, and usually that will be because of some mutation or a cytogenetic abnormality in the stem cell. So basically it's a clonal stem cell problem. It is called as myelodysplastic syndrome, MDS. So we're going to have dysplastic or abnormal maturation, and you can see those dysplastic cells accumulating in the bone marrow and spilling over in the peripheral blood as well. In MDS, invariably there will be some defect in the maturation process also, so that's why you're going to have accumulation of these precursor cells sometimes, and you will invariably see some blasts in the bone marrow as well as in the peripheral blood in case of MDS. But the idea in MDS is very simple. You're going to have predominantly dysplastic cells, and the amount of blast by definition should be less than 20%. You don't see that much of blast. On the other hand, if the problem predominantly is defective maturation, if you're having a defective maturation predominant, if that is the main problem, you're going to have too much of blast in the peripheral blood or probably in the bone marrow, and that situation is what we call as acute leukemia. Because you're talking about myeloid neoplasms, I can just talk about AML, that is acute myeloid leukemia, which is technically defined as number of blasts more than 20%, the proportion of blasts more than 20% in the peripheral blood or probably in the bone marrow. There are some standard exceptions to the rule. We'll talk about that. There are some classic cytogenetic abnormalities like T821 and T1517, that is your acute promyelocytic leukemia, and inversion 16 or T1616. These are basically classic cytogenetic changes of AML. In those situations, even if your proportion of blasts are less than 20% in the bone marrow, it doesn't really matter. If those changes are there, you're going to make a diagnosis of AML. So that is something that we're going to discuss later on, not here in the acute leukemia section. But as of now, I can say if the main problem is defective maturation that results in the proportion of blast being more than 20% in the bone marrow or probably in the peripheral blood, you're going to call it as acute leukemia. Because you're talking about myeloid neoplasms, let me stick on to the term AML, acute myeloid leukemia. So now we can understand what is the difference between your MDS and AML. So what is myeloproliferative neoplasm, by the way? So if there is a mutation or a cytogenetic abnormality in the stem cell, like as usual, you're going to have a clonal stem cell problem that's going to result in increased maturation. So because of that mutation or probably a cytogenetic change, you're going to have increased, not a defective or a dysplastic maturation. You're going to have increased maturation of cells. You're going to call it as myeloproliferative neoplasm. That's why it's basically called as MPN, myeloproliferative neoplasms. You're going to have more proliferation. So in this situation also, you will see some blast because there will be increased proliferation of these precursor cells as well. So there will be slight increase in the number of blasts, but still the blast count will be less than 20%. but you're going to see more and more precursor cells and mature cells, especially the mature cell number will increase. So that is myeloproliferative neoplasm. The classic example is a CML, chronic myeloid leukemia, or you can call it as essential thrombocytosis. These are classic examples of myeloproliferative neoplasms. And there are some patients who tend to have overlap disorders, like they tend to have myeloproliferative neoplasms. In the sense, there will be more proliferation of these mature cells, plus at the same time, there will be dysplastic, that maturation will be abnormal and dysplastic as well. So this is called as MPN MDS overlap disorders. So alright, now you would have got a little bit of idea about what are these disorders in the first place. Now it's time that we look at the WHO classification of myeloid neoplasms. So we have a terminology called as MDS, we know that. We have terminology called as MPNs, we know that. AML, MDS, MPN overlap. So these are the four most important things we have discussed already. Apart from that, there are some myelodysplastic syndromes due to PDGF receptor, FGF receptor rearrangements, or probably due to PCM1 JAK2 rearrangements. And there's another condition called as systemic mastocytosis, which is typically due to a KIT mutation called as KIT D816V mutation. And we have some myeloid neoplasms with germline predispositions as well. So what is basically MDS, or myelodysplastic syndrome? So as I said, it's a kind of a dysplastic clonal myeloid stem cell disorder. So where the main problem is dysplasia. And what are the features? Patients are going to have cytopenias because of dysplastic maturation. There will be cytopenias. It could be single lineage, or it could be more than one lineage as well. Most of the times it's going to be a multilineage dysplasia and multilineage cytopenia. And the blast count by default, by definition, it should be less than 20%. We discussed already. And these patients are at increased AML risk as well. Technically, all these disorders are due to some clonal problem in the stem cell. It's a clonal stem cell disorder. So any of these disorders like MDS, MPNs can ultimately get transformed into an acute myeloid leukemia. So that's a very, very important point. High risk of AML in both MDS as well as myeloproliferative neoplasms. So what about myeloproliferative neoplasms? So here the issue is more production of these mature cells. So you're going to have a non-dysplastic multipotent myeloid stem cell clonal expansion. Simple. That's all. We know what is that. So what do you mean by AML, acute myeloid leukemia? Because of the block in differentiation, block in maturation, you're going to have accumulation of these precursor cells called as blasts in the bone marrow and the peripheral blood. By definition, it should be more than 20%. We discussed already. And it's also a clonal myeloid stem cell disorder. And what is MDS, MPN overlap? So these patients are going to have features of both MDS as well as MPN. The best example for that will be a CMML, that is chronic myelomonocytic leukemia, and we have another terminology called as atypical CML. We'll talk about that later on. And what are these MDS or MPNs due to PDGF receptor, FGF receptor rearrangements? So these are nothing but myeloid or lymphoid malignancies that are usually associated with eosinophilia. That's a very important point. Usually associated with eosinophilia, especially that PDGF receptor, FGF receptor rearrangements is going to result in a kind of a hypereosinophilic syndrome. And these patients may have a good response to tyrosine kinase inhibitor therapy, especially imatinib. So especially if they're having PDGF receptor, FGF receptor rearrangements, most of these patients are going to respond to imatinib. But if you look at systemic mastocytosis, even though it's associated with KIT mutation, it's D816V mutation. Classically, in this mutation does not really respond to imatinib. So remember, your PDGF receptor rearrangements are going to respond to imatinib, but your KIT D816V mutations that is seen in systemic mastocytosis will not respond to imatinib. Other types of KIT mutations can be responsive to imatinib, like what you see in GIST. There also you have a different type of KIT mutation, but that is responsive. That's going to respond to imatinib. But this type of KIT mutations will not respond to imatinib. And what are the myeloid neoplasms that have germline predisposition? So if it occurs in the setting of Fanconi anemia or conditions that affect the telomeres like dyskeratosis congenita, or it's going to occur in certain conditions like Down syndrome or GATA2 deficiency or Shwachman-Diamond syndrome, or if it's due to CBPA mutations. These are basically germline mutations. So that's going to predispose to the development of certain myeloid neoplasms, especially MDS and acute myeloid leukemia. So that's it. So this is the WHO classification of myeloid neoplasms. Now let us move on to the discussion on individual disorders. First, I'm going to talk about myelodysplastic syndrome. Again, let us look at the definition one more time. So it's an acquired disorder. It's not a inherited or a disorder due to germline mutations, and basically an acquired disorder in most patients. And you're going to have a dysplastic maturation of the stem cells. So it's kind of a dysplastic clonal stem cell disorder. That's going to lead to ineffective erythropoiesis, which in turn is going to result in cytopenias. And in the bone marrow and in the peripheral blood, you can see this dysplastic abnormal dysmorphic cells along with precursors. There could be some blast, but technically the blast count should be less than 20%. And there is a high risk of leukemic transformation as well. High risk of getting converted to acute myeloid leukemia. MDS is characteristically a disease of old age. Most of the patients will be in the 70s and 80s. And it's going to predominantly affect males compared to that of females, with one probable exception will be your isolated 5q deletion syndrome. We'll talk about that. Apart from that, most of the MDS is going to be common in males compared to that of females. So coming to the etiology, MDS can be completely idiopathic without any identifiable background cause, or it can be due to secondary to some chemotherapy agents. So the most important chemotherapy agents are going to be your DNA topoisomerase 2 inhibitors, and your alkylating agents. So these are the two most important group of drugs that can result in both MDS as well as AML, and exposure to high dose radiation in the past is also going to increase the risk of MDS and AML. I think we'll be discussing about these details in the AML section in acute leukemias. And benzene is a very, very important compound that can result in various myeloid neoplasms, including MDS as well as AML. This has been asked so many times in exam. And what is going to be the pathophysiology and disease biology when it comes to MDS? Most of the case of MDS will be due to mutation of genes that are involved in the epigenetic process. You know, what do you mean by epigenetic changes? These are changes that are not going to affect the sequence of a particular gene or sequence of DNA. You're not going to touch it, but rather you're going to modify the genetic expression with the help of certain changes on top of this DNA molecules or genes, with the help of something like DNA methylation and demethylation, and histone modification, which can be histone acetylation as well as deacetylation. You know that DNA methylation and histone deacetylation is going to silence a gene, and apart from that, DNA demethylation and histone acetylation is going to increase the gene expression. So going to change the way how a gene is going to get expressed with the help of these changes that are not going to occur at a genetic level or at a DNA level, but on top of it, like methylation and acetylation. So that's why these are called as epigenetic processes. There are some very important genes that are involved in this epigenetic process, like DNMT3A, TET2, and IDH1/2, isocitrate dehydrogenase 1 and 2. So you'll be surprised to see this, because IDH is an enzyme of the Krebs cycle, but that is related to epigenetic process. So that's true. We'll talk about that probably in the oncology section, not here. So these mutations can result in MDS, or certain genes that are involved in histone modification, like ASXL1, EZH2, so can result in MDS as well. And there are some genes that are involved in RNA splicing, like SF3B1, where the classic mutation is the K700E mutation, or the mutation can be in another gene called as SRSF2, where the classic mutation is the P95H mutation, or there could be mutation in another gene called as U2AF1. So these mutations also can result in myelodysplastic syndrome. In that, the SF3B1 gene mutation is actually quite important for exams, at least at an SS level, because this is going to be associated with a specific type of MDS called as MDS of ringed sideroblast type. You're going to produce more of ringed sideroblast. And usually the diagnosis of MDS of ringed sideroblast will be made if more than 15% of the cells are ringed sideroblast in the bone marrow. The only exception for that rule is SF3B1 mutations. With SF3B1 mutations, even 5% ringed sideroblast is enough to make a diagnosis of MDS with ring sideroblast. So that's why the cutoff will be different for SF3B1 mutation. So let me repeat the genes again: GNMT3, TET2, IDH12, ASXL1, EZH2, SF3B1, SRSF2, and your U2A F1 mutations. So what are the other genes that are involved in the development of MDS? RUNX1 rearrangements, the transcription factor, TP53 mutations, NRAS, KRAS, and STAT2 mutations. These are quite non-specific, not very specific for MDS. Remember, the FLT3 mutations and nucleophosphate NPM mutations are basically AML specific. It is not seen in MDS, a very important point to know. So whenever you see FLT3, FMS like tyrosine kinase 3, so FLT3 mutations and nucleophosphate 1, NPM1 mutations, it's almost equivalent to AML. You don't see these mutations anywhere else. These are signature AML mutations. You don't see that in MDS. And there are some cytogenetic abnormalities that are characteristic of myelodysplastic syndrome, like trisomy 8. Plus 8 means trisomy 8. Loss or partial deletions of chromosome 5 and 7. It can be like complete loss of chromosome 5. It can be partial loss of chromosome 5, like 5q deletion, or it can be complete loss of chromosome 7, or it can be partial loss of chromosome 7 in the form of 7q deletion, and deletion 20q. So 20q deletion. These are some signature cytogenetic abnormalities that you encounter in the setting of myelodysplastic syndrome. And coming to diagnosis of myelodysplastic syndrome, first let us talk about the clinical manifestations of MDS. Most of the patients are going to present with unexplained cytopenias. Very important point. And the most common cytopenia will be anemia. Any elderly patient who's presenting with unexplained anemia, which is predominantly a macrocytic anemia, is almost always diagnostic of MDS in exams. Elderly macrocytic anemia that cannot be explained by anything else, like B12 deficiency, for example. It is equal to MDS by default in exams. So as I said, the most common cytopenia, 85% cases, is the anemia, where the hemoglobin by definition will be less than 10 grams per deciliter, and most of the times you're going to have a macrocytic anemia without much of megaloblastic changes though. And sometimes the dysplastic changes can be confused with megaloblastic changes, but both are quite different. And what will be the MCV? MCV will be usually in the 100 to 110 range. Generally, it will be mildly elevated, but it will be less than 120. That's a very important point. If the MCV exceeds 120, usually it will be a megaloblastic anemia due to B12 or folate deficiency. But in most cases of MDS, the MCV will be in the range of 100 to 110, generally around 105, 106. So it will be slightly elevated, not more than that. And the second most common cytopenia is going to be neutropenia. In some cases, thrombocytopenia, but Harrison clearly mentions it's neutropenia. Seen in 50% of the cases approximately, which is defined as an absolute neutrophil count of less than 1,800. Some textbooks use a count of 1,500 though. And number 3, thrombocytopenia. The third cytopenia that can occur is thrombocytopenia, which can occur in 40 to 65% of the patients. And it is defined as having a platelet count of less than 1 lakh by definition. And how about the diagnosis of MDS? Number 1, as I said, patients will be having unexplained cytopenia. That's a very important point. You should not be able to be explaining the cytopenia with anything else. Plus, at the same time, they'll be having evidence of dysplasia, typically a multilineage dysplasia in the peripheral smear as well as in the bone marrow. And there should be like at least 10% dysplastic cells by definition. And there can be blast, but the blast count should be less than 20% by definition. Again, plus or minus, they can have ring sideroblast in the bone marrow as well. So unexplained cytopenias plus evidence of multilineage dysplasia or single lineage dysplasia in peripheral smear and in the bone marrow, and by definition the number of dysplastic cells should be more than 10%. You can see blast, you can see ring sideroblast, but by definition the amount of blast should be less than 20%. So you have to definitely look for the cytogenetic and the molecular abnormalities. So you know what are the cytogenic abnormalities, like 7q deletion, loss of chromosome 7, 5q deletion, loss of chromosome 5, 20q deletion, and so on. There are a lot of cytogenic changes we discussed, and molecular abnormalities like ASXL mutations, then your TET2 mutations, then your SF3B1 mutations. Some molecular abnormality will be there, and all of them carry not only a diagnostic significance, but more importantly, a prognostic significance. Prior to diagnosis of MDS, you have to definitely try and exclude alternative causes. at least important alternative causes. That's why I have mentioned about something called as unexplained cytopenia. To call it unexplained, I have to try and rule out some specific causes. Like for example, definitely I have to rule out AML or AML specific abnormalities. So that's why if you see more than 20% blast, you're going to make a diagnosis of AML for sure, not MDS. Even if there are dysplastic cells, if you see more than 20% blast, that's equal to AML, not MDS. Second, I have to rule out some MDS MPN overlap disorders like CMML, that is chronic myelomonocytic leukemia. So in exam, the clue will be monocytes more than 1000 with dysplastic changes. Monocytes more than 1000 the peripheral blood with dysplastic changes. And I have to rule out some secondary bone marrow changes due to B12 deficiency, folate deficiency, and copper deficiency. I told you so many times that copper deficiency can exactly mimic B12 deficiency in the hematologic presentation as well as in the neurologic presentation. And certain viral infections that can induce dysplastic changes has to be ruled out, like HIV, hepatitis, as well as parvovirus B19 infections. And certain other drug and toxins can result in MDS-like changes, like certain chemotherapy drugs, especially alkylating agents, and alcohol, especially if taken in excess. Lead poisoning as well as arsenic poisoning can also result in certain MDS-like changes. So that's why these has to be ruled out. So only all this has been ruled out, and if you have unexplained cytopenia dysplastic changes, you can make a diagnosis of MDS concretely. And coming to some important dysplastic changes in the setting of MDS. So first, let us talk about the dysplastic changes in the erythroid lineage. So the first one is an example of a ringed sideroblasts. Ringed sideroblasts are formed due to iron accumulation in the mitochondria in the RBC precursors, and it's a finding that will be seen only in the bone marrow, not in the peripheral blood. In the peripheral blood, you can see equivalent of ring sideroblasts, that is kind of Pappenheimer bodies, these are inclusion bodies. But nevertheless, so in the bone marrow, if you see iron accumulation in the mitochondria, that's going to form a kind of a ring around the nucleus. These are called as ring sideroblasts, and this is an example of a Pearl's Prussian blue stain because we are trying to demonstrate the iron accumulation. And this is another typical dysplastic change seen in erythroid precursors. This is called as nuclear bridging, clearly abnormal. It's an example of a dysplastic change, nuclear bridging. And you can also notice something called as cytoplasmic fraying, another important dysplastic change in the RBC lineage. So you can notice that there are some bits and pieces of cytoplasm that's coming out. This is what we call the cytoplasmic fraying. And you can also notice the multilobated nucleus in an erythroid precursor. So you should not see multilobate nucleus like this in an erythroid precursor. If you see that, it's clearly abnormal, it's a dysplastic change. And what are the abnormalities that you can see in the WBC lineage, especially in the granulocyte lineage? In the peripheral blood of this patient, you can notice something called as pseudo-Pelger-Huet kind of cells. These are basically pseudo-Pelger-Huet cells. The nucleus is like a kind of a spectacle, so pseudo-Pelger-Huet cells. And you can also notice a donut-shaped nucleus. A donut-shaped nucleus is another example of a dysplastic change, and you can also notice very poor nuclear maturation along with something called as Dole bodies. So these are examples of Dole bodies, what you're seeing over here. And the nucleus is abnormal because the chromatin condensation is not that great here. It's poor. Plus at the same time, this neutrophil is hypogranular. You don't see enough number of granules. So I can say this is a hypogranular neutrophil. And here's an example of again poor or a defective nuclear maturation where the chromatin condensation is not that good. And on top of that, you're also noticing a blast nearby. So this is an example of a blast. I told you in MDS, of course you can see blasts, but the count should be less than 20%, I told you. And here's an example of abnormalities in the megakaryoid lineage. Megakaryoid lineage, where you're noticing multiple small nucleus within the megakaryoid lineage, and this is what we call as pond ball megakaryocyte. Pond ball megakaryocyte, clearly abnormal. And here's an example of a very small megakaryocyte. These are also called as micro megakaryocytes. Micro megakaryocytes, again an example of a dysplastic change, and here is an example of a hypogranular and a giant platelet. Hypogranular platelets, which is also an example of a dysplastic change. So these are some important dysplastic changes. Among this, if you ask me, the most important that can be asked in exam will be the ring sideroblast, the pseudopelgar cells, and the pond ball megakaryocytes, which is something that has been already asked in exam. That's why I've given these changes in the first. So don't forget the ring sideroblast, the pseudopelgar cells, and the pond ball megakaryocytes. So what about other terminology? We have some confusing terminologies apart from MDS, like CHIP, that is clonal hematopoiesis of indeterminate potential. Then we have something called as ICUS, that is idiopathic cytopenia of undetermined significance. And then we have CCUS, that is clonal cytopenia of undetermined significance. You don't see dysplasia in any of these disorders, but you're going to have cytopenias in ICUS and CCUS, but not in CHIP. And clonality will be seen in CHIP as well as in CCUS, but not in ICUS. That's why it's called as idiopathic cytopenia of undetermined significance. If you look at the risk of getting transformed into MDS or AML, the risk is actually quite high with CCUS, that is clonal cytopenia of undetermined significance. The risk is actually low with your CHIP and idiopathic cytopenia of undetermined significance. I'll try to put everything in a kind of an algorithm in the next slide, don't worry. But before that, let us look at the WHO updated classification of myelodysplastic syndromes. So the old classification used some terminologies like refractory cytopenia of undetermined significance, like refractory anemia, refractory neutropenia, refractory thrombocytopenia. All these have been put currently under an umbrella term called as MDS with single lineage dysplasia. And then we had an old term called as refractory cytopenia with multilineage dysplasia. All this has been put under a single umbrella term called as myelodysplastic syndrome with multilineage dysplasia. And third, we had something called as RARS, that is refractory anemia with ring sideroblast. Now the new term for that is MDS with ring sideroblast. Then we had deletion 5q syndrome associated MDS. So now this has been renamed as isolated 5q deletion, because 5q deletion is something that you can notice in other types of MDS also. But if it's isolated, if it's the only cytogenic change that is seen, so then it will be called as isolated 5q deletion. And if you have excessive blasts, you're going to call it as RAB1, RAB2, especially if you have more than 5% blast, it will be called as refractory anemia with excessive blast. And we have two categories. If the blast count is 5 to 9%, you're going to call it as RAB1. If it is in the range of 10 to 19%, you're going to call it as RAB2. But right now, the new terminology for that is myelodysplastic syndrome with excessive blast. That's it. In that, you have EB1, EB2. And finally, if it doesn't fit into any of the other classification systems, it will be called as MDS unclassified. That terminology has been retained in the newer classification system as well. So let us have a look at each and every single type, then I'll give you the algorithm. So first, MDS of single lineage dysplasia. Here, as the name implies, you're going to have only one dysplastic lineage, and patients can have approximately 1 to 2 cytopenias, typically a single cytopenia, most often an anemia. And by definition, they should have less than 15% ring sideroblast, and they should have less than 5% of blast in the bone marrow and less than 1% of blast in the peripheral blood, and they should not have any OIR rods. This is that definition. And then how will you define the features of MDS with multilineage dysplasia? Here, as the name implies, you're going to have 2 to 3 dysplastic lineages. Generally, you'll have more than one cytopenia, typically 1 to 3 cytopenia, which can be even a pancytopenia. And by definition, patients should have less than 15% ring sideroblast and less than 5% blast in the bone marrow and less than 1% blast in the peripheral blood and no OIR rods. And what do you mean by MDS of ring sideroblast type? So as the name implies, you should have significant number of ring sideroblasts, like more than 15% in the bone marrow. And only exception for this rule is your SF3B1 mutations, where even more than 5% ring sideroblasts can be diagnostic of MDS of ring sideroblast type. And again, by definition, the amount of blast in the bone marrow should be less than 5% and amount of blast in the peripheral blood should be less than 1% with no OIR rods in the blast. Because if you have OIR rods in the blast, it's usually going to make a diagnosis of your AML, acute myeloid leukemia, because they are AML specific. And what do you mean by isolated 5q deletion? In most cases, you're going to have the 5q deletion as the only cytogenetic abnormality. Apart from that, they can have one more abnormality by definition, but it should not be loss of chromosome 7 or 7q deletion. But in most cases, you're going to have an isolated 5q deletion, only 5q deletion as the abnormality. And what about MDS with excessive blast? As the name implies, you're going to have more blast. If you have 5 to 9% blast in the bone marrow and or 2 to 4% blast in the peripheral blood, Of course, you should not have oil rods. It will be called as excessive blast type 1. If you have 10 to 19% blast in the bone marrow and or 5 to 19% blast in the peripheral blood, but here you might have oil rods, but the amount of monocytes should be less than 1000 to rule out CMML. So then you can call it as excessive blast of type 2 MDS. And what is MDS unclassified? It doesn't fit into anything. So like for example, you have 1% peripheral blood blasts are less than that. And if you have a single lineage dysplasia along with pancytopenia, so this really doesn't fit into anything. So that's why it's called as MDS of unclassified type. And what about 5q deletion syndrome? It's a very unique syndrome, to be honest. It's a very unique disease where the patients are going to have progressive anemia with preserved or even increased platelets. In MDS, you usually encounter cytopenias, but this is a condition where you can have thrombocytosis. That's why this is very, very important for exams. You're going to have progressive anemia with preserved or even increased platelets. Thrombocytosis can occur. And I told you MDS is quite common in males usually. That's what I discussed. I told you that time itself the only exception is 5q deletion syndrome, where females are going to be commonly affected compared to that of males. And typically the isolated 5q deletion syndrome tend to have a benign clinical course, which means they're going to have a lower risk of transforming into AML, that is acute myeloid leukemia. And most of the cases are going to have dyserythropoiesis and micromegakaryocytes. This is a very important change in isolated 5q deletion. It's very, very common and seen in more than 80%, 4/5 of the cases. And most of the cases are going to excellently respond to lenalidomide, which means it's actually treatment of choice for your isolated 5q deletion. And with the help of lenalidomide, most of the patients tend to achieve transfusion independence and a complete cytogenetic response. CCYR means a complete cytogenetic response. So let us try and put everything in the form of an algorithm. So whenever a patient is presenting with unexplained cytopenia, so let me write a patient is presenting with unexplained cytopenia. So you have to see whether is there any dysplastic changes. Is there any dysplastic changes? By definition, you should have at least more than 10% dysplastic cells in the bone marrow and or in the peripheral blood. If no, then you have to see whether the patient is having any evidence of clonality. So if you don't have any significant dysplastic changes, look for evidence of clonality. If you have clonality, it will be called as clonal cytopenia of undetermined significance, which basically has a higher risk of getting transformed into MDS or AML. If you don't have clonality, it will be called as isolated cytopenia of undetermined significance. Technically, it has a lower risk of getting transformed into MDS and AML. On top of that, we have another important terminology called as CHIP, that is clonal hematopoiesis of indeterminate potential. So where you're going to have evidence of clonality, there will be clonality, but you don't have cytopenias. No cytopenias and no dysplastic changes as well. No dysplastic changes as well. This is what we called as clonal hematopoiesis of indeterminate potential, and that is also going to have a kind of a low risk of getting transformed into MDS or AML. So, but in exam, they might ask about CCUS or ICS and how will you differentiate them. So, if you are going to have significant number of dysplastic cells, more than 10% dysplastic cells in the bone marrow and or in the peripheral blood, you have to always look at the blast count, percentage of blast. If the percentage of blasts are more than or equal to 20%, it is equal to AML, acute leukemia, unless proved otherwise. That's it. If you're going to have less than 20% blasts, now next step is to rule out the MDS MPN, overlap syndromes. The most important MDS MPN that you have to rule out is CMML, that is chronic myelomonocytic leukemia, where monocytes will be more than 1000 with dysplastic cells. Monocytes in the peripheral blood will be more than 1000 along with dysplastic changes. So if monocytes are less than 1000, for example, you have ruled out CMML. Now the next step is to again look at the exact blast proportion. If the blast proportion is less than 5%, you're going to make a diagnosis of MDS of ring sideroblast type or single lineage dysplasia or multilineage dysplasia or even unclassified type. If the blast proportion is more than or equal to 5% in the bone marrow, I'm talking about in the bone marrow, if it's more than or equal to 5%, then you're going to make a diagnosis of MDS with excessive blast. In that, if your blast proportion is 5 to 9% in the bone marrow, it will be called as MDS of excessive blast type 1. If it's in the range of 10 to 19%, in these patients alone, you can notice the presence of some degree of oil rods because there's an extremely high risk of getting transformed to AML. If you have MDS of excessive blast type 2, where the proportion of bone marrow blast will be in the range of 10 to 19%. If it's less than 5%, you have to notice the proportion of ringed sideroblasts. If it's more than or equal to 15%, it will be called as MDS of ringed sideroblast type, previously called as RARS or refractory anemia with ringed sideroblasts. But remember, the only exception to the rule is SF3B1 mutations, where the cutoff is 5% of ringed sideroblasts, not 15%. That's the only exception to the rule. If the proportion of ringed sideroblasts are less than 15%, then you have to see how many lineages are dysplastic. You have to see how many lineages are dysplastic. If only one lineage is dysplastic, you're going to call it as MDS of single lineage dysplasia type. If more than or equal to 2 lineages are dysplastic, you're going to call it as MDS with multi-lineage dysplasia. On top of that, only 2 things that is not included in the algorithm is going to be the isolated 5q deletion and probably MDS of unclassified type. So that's it. So this is how you're going to evaluate a patient, especially elderly patient who's presenting with unexplained cytopenia. And coming to prognostication of myelodysplastic syndrome, we are currently using the International Prognostic Scoring and Staging System, IPSS-R, which is actually revised in 2013, I guess. And we're going to use 5 variables in that revised prognostic system. One is cytogenetics, second is bone marrow blast, third is hemoglobin, fourth is platelet count, and fifth is absolute neutrophil count. So technically what we are looking at is, we are looking at cytopenias in the form of anemia, thrombocytopenia, and neutropenia. And we are looking at the proportion of bone marrow blast. If you have more blasts, the risk is always higher. And we are going to look at cytogenetics, whether it's a very good or intermediate or poor or very poor cytogenetic change. So accordingly, you can score. So you can give a score of 0 if the patient is having very good cytogenetics, and or if the patient is having a bone marrow blast of less than 2%, if the hemoglobin is more than 10, if the platelet count is more than 1 lakh, if the neutrophil count is more than 800, I'm going to give a score of 0. When can I give a score of 0.5? So if the platelet count is in the range of 50,000 to 1 lakh, and or if the neutrophil count is less than 800, I'm going to give 0.5 points. When you're going to give 1 point, if you have a good cytogenetics, and the bone marrow blast is in the range of 2 to less than 5%. If the hemoglobin is in the range of 8 to 10 grams per deciliter, if the platelet count is very low, like less than 50,000, you're going to give a score of 1. When you're going to give a score of 1.5, if the anemia is very severe, like hemoglobin less than 8 grams per deciliter, I'm going to give a score of 1.5. When I'm going to give a score of 2, 3, and 4 only with the help of the proportion of blasts and the cytogenetics. So score of 2, 3, and 4 will not be decided based on cytogenetics. That's a very important point as well. If you have intermediate cytogenetics and or if you have a bone marrow blast proportion of 5 to 10%, you're going to give a score of 2. If you're going to have a poor cytogenetics, or if the proportion of bone marrow blast is more than 10%, I'm going to give a score of 3. If you have very poor cytogenetics, you're going to give a score of 4. So score of 4 will depend only on cytogenetics, not on anything else. So 5 variables, at least the variables has to be known in exam. So cytopenia is fine. So hemoglobin, platelet count, ANC. And apart from that, bone marrow blast and cytogenetics are also very, very crucial. Now we have to talk about the cytogenetic risk groups. We have talked about very good, good, intermediate, poor, very poor cytogenetics, but what are they basically? Loss of chromosome Y and 11q deletion is a kind of a very good cytogenetic change, which means this is associated with excellent prognosis. If the patient is having normal cytogenetics, that can be seen in a proportion of patients like 10 to 20%. It's associated with good prognosis. 5q deletion, 12p deletion, 20q deletion is also associated with good prognosis. Whereas 7q deletion, trisomy 8, trisomy 19, and isochromosome 17q. I stands for isochromosome 17q. This is associated with intermediate prognosis, not good, not bad. Loss of chromosome 7, that is monosomy 7, inversion 3, which can also be written as translocation 33 or T33, and complex cytogenetics with 3 abnormalities is associated with poor prognosis. And complex cytogenetics with more than 3 abnormalities is going to indicate very poor prognosis. It's a very high risk cytogenetic change. And based on IPSSR scoring, you can compile all the parameters and you can compile the score as a whole, and you can tell the risk of the patient. You can categorize the risk. If the score is less than or equal to 1.5, it indicates a very low risk. 1.5 to 3 indicates a low risk. More than 3 but less than 4.5 indicate an intermediate risk. More than 5 but less than 6 indicate a high risk. If it's more than 6, it indicates a very high risk. You can notice that as the risk category increases, the median survival keeps on decreasing. Like for example, if the patient belongs to a very low risk group, then the median survival is 8.8 years, which means almost a decade. But if the risk category is very high, the score is more than 6, then the median survival is not even a year. And if you look at the risk of getting transformation into acute myeloid leukemia, it's actually highest with very high risk group, which means as the risk category increases, the risk of getting transformed to AML also increases substantially. For that matter, you can notice that the median number of years that takes for AML transformation in a low risk group is 10.8 years. And the median number of years for getting transformed into AML in a very high risk category is not even a year. It's just 0.73 years. Okay. Now let us talk about the treatment of myelodysplastic syndrome. First of all, you need to know the performance status of the patient. In case the patient is having multi-organ failure, lots of comorbidities, very old patients, elderly, frail patients, or you can also use ECOG or Karnofsky performance status. If the patient is in the ECOG 3-4 range, it indicates a poor performance status. If the patient is belonging to ECOG 0 to 2, it indicates a good performance status. What is that ECOG performance status? We'll also be discussing this in the oncology section. Don't worry about that. If the score is 0, it indicates that the patient is fully active without any performance restrictions whatsoever. No loss of any sort of activity. The score is 1, patient will be having some restrictions, especially with strenuous physical activity, otherwise completely ambulatory. If the score is 2, it indicates that the patient is capable of self-care but unable to carry out any work activities, and the patient is up and about more than 50% of the waking hours. If the score is 3, it indicates that the patient is capable of only limited self-care. Certain elements of self-care has to be coming from the people in the house or probably from the staff nurse, and the patient is confined to the bed or chair for more than 50% of the waking hours, which means they are up and about for less than 50% of the waking hours. If the score is 4, it means that the patient is completely disabled, totally bedbound, confined to bed, and cannot carry out any self-care without assistance, right? So most of these patients will be requiring a kind of a home staff nurse at least 24/7. In case if the patient belongs to poor performance status, that is ECOG 3-4, all we are going to try and opt is for basic supportive care. That's it. In the sense, you're going to support the cytopenias. For example, anemia with PRBC transfusions and or erythropoietin injections. The neutropenia with GCSF like filgrastim or pegylated filgrastim. The thrombocytopenia can be supported with TPO mimetics like romiplostim or TPO receptor agonists like L-Trombopag. And in case the patient is having recurrent infections, you can even consider prophylactic antibiotics. If the patient is belonging to good performance status, then you can try and do some definitive therapy in the form of hypomethylating agents, lenalidomide, or even a hematopoietic stem cell transplantation. For that, we need to know the risk. If the patient is in the low or intermediate risk category, like for example, if the score is less than or equal to 4.5 in the IPSSR, then you can consider the use of either lenalidomide or hypomethylating agents. Lenalidomide is especially effective for 5q deletion syndrome. We discussed that already. It can result in a complete cytogenetic response in a vast majority of patients. And hypomethylating agents can be tried for other group of MDS apart from the isolated 5q deletion. So what are the hypomethylating agents? These are DNMT inhibitors. We'll talk about that later on in the oncology section as well. These drugs are nothing but azacitidine and decitabine. In case if the patient is belonging to high risk or very high risk category, like for example more than 4.5 or more than 6 in the IPSSR, then you have to consider allogenic hematopoietic stem cell transplantation if the patient is fit, or if the patient is unfit, then you can consider hypomethylating agents like azacitidine or decitabine. You have a rare form of MDS called as hypoplastic myelodysplastic syndrome. That's called as hypoplastic MDS. So this will be treated very similar to that of aplastic anemia. It's a rare form. So where you can either consider hematopoietic stem cell transplantation if the patient is fit, plus if the patient is having a matched sibling donor, or alternatively you can consider the triple therapy, that is immunosuppression protocol with calcineurin inhibitor, anti-thymocyte globulin, typically a horse ATG, plus an L-Trombopac. We have discussed that already in the bone marrow failure section. So that's it about the treatment of MDS as well. Now it's time that we move on to myeloproliferative neoplasms. And that the most important myeloproliferative neoplasm for exam is going to be CML, which is nothing but chronic myeloid leukemia. We have already discussed enough about the basic concepts of myeloproliferative neoplasms. Now we have to discuss about the definition of CML. CML is nothing but an MPN with proliferation of the granulocyte lineage. That's it. So basically it's a myeloproliferative neoplasm where you're going to have uncontrolled proliferation of mature as well as maturing granulocytes. But you won't have that much of a differentiation block or defective maturation. So that you might see some blasts, but it cannot be more than 20%. It will be less than 20%. In most cases, it's going to be less than 5%, especially in the chronic phase of CML. So what is the definition? Exact definition. It's a myeloproliferative neoplasm with clonal stem cell disorder with a dysregulated production and uncontrolled proliferation of mature or maturing granulocytes. Plus or minus, patients can have cytopenias also. So basically, it's a problem of granulocyte lineage. That's all. So what is the epidemiology of CML? The median age at the time of diagnosis of most cases of CML is going to be 55 to 60 years. And it's going to contribute to 15 to 20% of adult leukemias. The most common adult leukemia is actually AML. But CML contributes approximately 15 to 20% of adult leukemias. But basically, we don't consider CML as a leukemia in the first place. Rather, we consider CML as a clear-cut myeloproliferative neoplasm. And what are the risk factors for CML? So certain studies suggest that the risk is going to increase with radiation therapy. But overall, there is no clear relationship to cytotoxic drugs or probably with benzene. You know that AML as well as myelodysplastic syndrome is strongly related to cytotoxic drugs and benzene, but CML is not related. Maybe a slightly increases with radiation therapy. Apart from that, no relationship to benzene and cytotoxic drug. A multiple times asked question in exams. Coming to tumor biology. So it has a unique tumor biology in the form of something called as Philadelphia chromosome. This is a classic cytogenetic change that you see in CML. In fact, according to the WHO guidelines, you cannot make a diagnosis of CML unless and until you have Philadelphia chromosome, which means 100% all the cases should have Philadelphia chromosome if you want to make a diagnosis of CML. So what is that Philadelphia chromosome? It is nothing but BCR-ABL fusion. That's going to occur in chromosome 22, or we can call it as the T922, the famous T922 translocation, in that the chromosome 92 is what we call it as Philadelphia chromosome, where BCR and ABL1 is going to fuse. BCR is also called as breakpoint cluster region, and ABL1 is a kind of a kinase, tyrosine kinase. Because of the fusion with BCR, you are going to produce a new fusion kinase, new fusion protein that has dysregulated and excessive tyrosine kinase activity. And that is the very basis of CML in the first place. And to be honest, the Philadelphia chromosome is the first tumor-specific chromosome change ever discovered. In exams, they might ask who discovered it. By two scientists named Dr. Peter Nowell and Dr. Hungerford in 1960s. It's the first tumor-specific chromosomal change ever discovered, period. The fusion protein that is formed because of BCR-ABL1 fusion has a dysregulated tyrosine kinase activity that's going to result in accelerated proliferation, and this can progress to accelerated phase and blast crisis. Most of the patients are going to present with chronic phase. I'll talk about that, but over time they start developing accelerated phase and blast crisis. Blast crisis is the ultimate end point if you don't treat them, and most of them invariably will die once the blast crisis occurs and if you're not going to treat for it. And the BCR-ABL fusion is going to result in 3 different types of fusion proteins. The P210, P230 and P190, which is basically based on the molecular weight of this protein. The P210 is the intermediate weight form, 230 heavy weight and 190 lesser weight. So 210 is called as the classic breakpoint because it's seen in almost all the cases of CML, but it can be seen in 30% of Philadelphia positive ALL as well. 230 is called as the alternate breakpoint, which is kind of rare in both CML as well as ALL cases. The P190 breakpoint, though, it's kind of rare in CML, but it is the most common type of fusion protein that is seen in ALL patients. So 70% of Philadelphia positive ALL patients are going to have the P190 fusion protein only. P210 is the one that's commonly seen in CML cases though. And to be honest, Philadelphia positivity, as I said so many times, is required for the diagnosis of CML. Without that, you cannot make a diagnosis of CML. But remember, Philadelphia positivity is kind of non-specific for CML in the sense it can be seen in approximately 30% of the childhood ALL and approximately 1 to 5% of the AML cases as well. So technically, Philadelphia positivity is required for the diagnosis of CML, but you cannot make a diagnosis of CML only with Philadelphia positivity. Even though it's a prerequisite, you cannot make diagnosis of CML only with Philadelphia positivity. You need other things like your peripheral blood and bone marrow finding and so on. We'll talk about that. And as I said, Philadelphia positivity is not required for the diagnosis of ALL or AML, but it's going to tell you the prognosis, especially in ALL, in childhood ALL. If you have Philadelphia positivity, that indicates worse prognosis. Even in AML, if you have Philadelphia positivity, it's going to indicate worse prognosis. But for CML, it is not basically going to prognostify anything. Rather, it's required for diagnosis. That's the point that you need to know. So look at what is Philadelphia chromosome and what is the reason for CML in the first place. You're going to have a region called as BCR region, that is breakpoint cluster region chromosome 22. And that's going to fuse with another gene called as ABL gene in chromosome 9 because of the translocation, that is T922, that's going to occur. And this fusion of BCR and ABL together, it's going to result in a new fusion kinase that's called as BCR-ABL kinase. And that's going to have a dysregulated tyrosine kinase activity, and that's the reason for development of CML in the first place. And here's a kind of the molecular structure of the BCR-ABL fusion kinase. And you have something called as active site, which is basically the ATP binding site of this tyrosine kinase. And this is the place where you're going to target in terms of tyrosine kinase inhibitors like imatinib. So the active site, the ATP binding site of the CAT domain is the one that's going to be targeted by most of the tyrosine kinase inhibitors. Coming to the clinical features of CML. So 30 to 50% of the cases will be diagnosed incidentally, which means they will be asymptomatic at the time of presentation, which means you're going to just make a diagnosis with the help of CBC, which is done randomly, probably in a mastoid checkup. And remaining patients are going to present with issues probably due to cytopenias. The most common cytopenia is anemia, so patients can present with fatigue, or patients can have thrombocytopenia that can result in bruising. And patients can present with weight loss just because it's a leukemia, it's a cancer. And patients can present with B symptoms, patients can present with splenomegaly as well. In most cases of CML, are going to have a moderate to massive splenomegaly, everyone knows that. CML generally follows 3 classic phases, but in the modern tyrosine kinase era, this classic triphasic course is uncommon because we're going to halt the progression most of the times in the chronic phase itself. So if you don't take a tyrosine kinase inhibitor like imatinib, the chronic phase is going to last for 3 to 5 years approximately. The accelerated phase is going to last for 12 to 18 months, and the blast crisis phase is going to last for 3 to 9 months. So chronic phase is the most common phase at the time of presentation, which means 85% of the patients are going to present in the chronic phase. And by definition, the percentage, the proportion of blasts in the bone marrow and or in the peripheral blood should be less than 10%. That's a very important number. If it's more than 10%, it becomes accelerated phase. If it's more than 20%, it becomes a blast crisis. And you should not have any feature that's fitting in the accelerated phase diagnosis or blast crisis diagnosis. And most of these patients are going to commonly have thrombocytosis and a mild degree of basophilia. The basophilia is very characteristic of CML. Should never forget that. Basophil, one of the important cause of basophil in the world right now is CML. And most of the patients in chronic phase are going to have thrombocytosis rather than thrombocytopenia. And that is a very important point. Because once you enter accelerated phase, patients can encounter thrombocytopenia. And what do you mean by accelerated phase? If you have any one of this, you can call it as accelerated phase. So like for example, the proportion of blasts being more than 10% but less than 20%, that is 10 to 19% in the bone marrow and or in the peripheral blood. And or if the basophil count in the peripheral blood is more than 20%, which means the differential count with regards to basophils is more than 20. Or the patient is encountering thrombocytopenia that is not related to treatment with any chemotherapy or tyrosine kinase inhibitors, or if the patient is having extreme thrombocytosis, like more than 1 million, even that is kind of accelerated phase only, which is kind of unresponsive to therapy. Or if the patient is having progressive splenomegaly or worsening splenomegaly, or progressive increase in the WBCs that is not responding to your standard therapy, or if the patient is having evidence of clonal evolution. One of the important characteristic feature of cancer is clonal evolution. As time progresses, the new changes start appearing. They evolve more and more in terms of chromosomal abnormalities, cytogenetic changes, and with regards to new mutations as well. This is what we call as clonal evolution. So it is defined as development of new chromosomal abnormalities. Like for example, patients can develop additional Philadelphia chromosomes in the same cell. Patients can develop isochromosome 17q, which is a kind of a MDS-like change, or patients can develop trisomy 8, trisomy 19. So all this can occur as a part of clonal evolution. So most important thing to note as far as exams are concerned is going to be the percentage of blasts, severe basophilia, thrombocytopenia or extreme thrombocytosis, worsening splenomegaly and clonal evolution. 5 points, very important for exams to make a diagnosis of accelerated phase. So when you call it as blast crisis, whenever the proportion of blasts in the bone marrow and in the peripheral blood exceeds 20%, obviously, it's a kind of a like acute leukemia picture, and this is what we call it as blast crisis. Interestingly, only 2/3 of the patients will have myeloid blasts. 1/3 of the patients can actually have lymphoid blasts. Even though this is a chronic myeloid leukemia granulocyte problem, 1/3 of the patients tend to develop a lymphoid blast crisis. So that's kind of surprising. That's a very important point. So, but overall, because it's a myeloid neoplasm, 2/3 of the patients are going to develop a myeloid blast crisis only, which is going to mimic a AML in general. And these patients sometimes can even have extramedullary blastic infiltrates, which are basically called as granulocytic sarcomas or chloromas, just like AML. Alright, so now you know the three characteristic phases: the chronic phase, accelerated phase, and the blast crisis. Here's a look at the splenomegaly. In a patient who's suffering from CML, you can notice that the spleen is moderately enlarged here. It's approximately 5 centimeters below the left costal margin, and the CT of the same patient showing a gross splenomegaly. And as we know, most of the patients with CML are going to have a moderate to massive splenomegaly. How are you going to establish the diagnosis of CML? I can explain in the form of a triad. I have to look at the peripheral blood, or we can call it as a peripheral smear. Second, I have to look at the bone marrow histopathology as well. Then finally, I have to look at the cytogenetics. I have to prove the Philadelphia positivity, that is T922 translocation. So in the peripheral smear and in the bone marrow aspiration samples, what I'll be noticing is a prominent left shift. There will be increased proliferation of the granulocyte precursors of the mature granulocytes with a prominent left shift, because the precursors are also going to increase. In the peripheral smear, what you're going to notice is increased WBC count, increased total leukocyte count, of course, with a prominent left shift. And your maturation will be predominantly towards the granulocyte lineage. There will be more of granulocyte precursors and mature granulocytes. And one of the most important differential diagnoses of increased WBC is predominantly granulocyte lineage with a prominent left shift is leukemoid reaction. Leukemoid reaction. Obviously, patient will be having some underlying problem like sepsis if you want to diagnose leukemoid reaction. But traditionally in exams, what they tend to ask is the leukocyte alkaline phosphatase score, the lab score. Lab score will be generally high in the setting of a leukemia reaction, whereas if it's going to be a CML, the lab score is going to be low. In exam, if they mention that the lab score is decreased, invariably you're going to make a diagnosis of either CML or a paroxysmal nocturnal hemoglobinuria. These are the two classic conditions with low lab score. Of course, in bone marrow aspiration, also going to see almost the same thing, more of granulocyte precursors and mature granulocytes, and there will be a prominent left shift. And normally the myeloid erythroid ratio is going to be somewhere in 2 to 3:1, but when it comes to CML, it can expand to a value of even 10:1. So there will be myeloid hyperplasia, and the myeloid series will be too much in the bone marrow. So the increased myeloid erythroid ratio is characteristic of CML. And what about the cytogenetics? Now you have to prove the Philadelphia chromosome, right? The T922 translocation. This can be done with the help of karyotyping. But we don't prefer doing a conventional karyotyping in the modern era. Rather, we prefer something called as FISH, that is fluorescent in situ hybridization. FISH is the technique of choice. Ideally, karyotyping and FISH is best done in the bone marrow aspiration samples. That's the best sample for doing karyotyping and or probably FISH. But there is another investigation called as PCR, polymerase chain reaction. We're going to pick up the BCR-able fusion mRNA transcripts. This is going to pick up the BCR-able fusion mRNA transcripts. And the advantage of PCR is the fact that it can be done in both peripheral blood as well as in the bone marrow aspiration samples. So ultimately, I can conclude that for diagnosis, it's better to consider a bone marrow aspiration sample with FISH. So that's the best for diagnosis. But for following up a patient after starting treatment, your PCR will be better because you need not poke the patient again and again for bone marrow samples. Rather, you can do PCR in the peripheral blood sample itself. So for follow-up, you can do PCR in peripheral blood. For diagnosis, you can do FISH in the bone marrow sample. All right. So what you're going to see in karyotyping and FISH, you're going to prove the Philadelphia positivity, which means the actual translocation, the T922 translocation, and the 22nd chromosome is what we call as Philadelphia chromosome, right? So that is something that is proved with karyotyping and FISH. But as I said, in PCR, you're going to prove the presence of your BCR-able fusion mRNA transcripts. You know the central dogma of biology, right? So it starts with DNA, the gene basically, then mRNA, then finally you get the protein, right? Here the gene is the BCR-able fusion gene, the abnormal gene, the BCR-able 1 fusion gene. So that's going to produce the BCR-able 1 fusion mRNA. Ultimately, you're going to result in production of the BCR-able 1 fusion protein, or you can call it as the abnormal tyrosine kinase, the BCR-able 1 fusion kinase. So in PCR, we are trying to pick up the mRNA transcripts. All right. So if you have all three, then you can make a diagnosis of CML. So this is how you're going to arrive at the diagnosis. So let us have a look at it again. In the peripherals, we are going to look at leukocytosis, increased total WBC count along with left shift, and there should be all stages of myeloid maturation without much of maturation block. Plus or minus patients can have cytopenias, typically anemia plus or minus thrombocytopenia, and most of the patients are going to have basophilia. In chronic phase, usually you're going to have mild basophilia, but in accelerated phase, the basophilia can be extreme. The bone marrow, of course, is going to be hypercellular, and you're going to have high myeloid erythroid ratio, which I described already. And in the bone marrow samples, you can do cytogenetics. So it can be done with the help of either FISH, but FISH is or karyotyping, but the FISH is better, I told you. And this is to look for the fusion gene, BCR-able fusion gene. And you can also do RT-PCR, the real-time PCR. Quantitatively, you can pick up how much BCR-able fusion transcripts are there in the bone marrow or in the peripheral blood. So as I said, it can be done in the peripheral blood samples. That is why it is better for follow after starting therapy. It's very, very sensitive. And we have various risk scores for CML. Like for example, we have SOCAL index, we have Hasford Euro score, we have Utah score, and we have ELTS score. So what is SOCAL index? The variables alone are important for exams. SOCAL index is a classic traditional index for CML. So it depends on age, the spleen size, the platelets, and the percentage of blast in the peripheral blood, not in the bone marrow. If the SOCAL index is less than 0.8, indicates low risk. If it's 0.8 to 1.8, indicates intermediate risk. And if it's more than 1.2, indicates high risk. Then you have the Hasford Euro score. So apart from SOCAL index, it uses two additional variables, which means Hasford also utilizes age, spleen size, platelets, and the percentage of blast in peripheral blood. Plus, it includes the number of eosinophils as well as the basophils in the peripheral blood. Utah score is going to use only two variables, that is spleen size and the percentage basophils. According to Utah score, if it's less than or equal to 87, it indicates low risk. More than 87 indicates high risk. ELTS is also going to use the same variables as that of the SOCAL index or SOCAL score, but it's going to use a different mathematical calculation. That's all. So 4 scores, don't forget. SOCAL, Hasford, UTOS, ELTS. In that, SOCAL is the most important for exams. Here is an example of a patient with CML. And you can notice that in the peripheral blood, there is a prominent increase in the total leukocyte count. More number of WBCs are there with a prominent left shift, and you can see a lot of promyelocytes, metamyelocytes, and to some extent some myelocytes as well. So one blast-like appearing cell is also there, but we are not very sure about it. So this is a kind of a high WBC count with a prominent left shift, but this alone cannot make a diagnosis of CML. We know that. We need to have evidence in the bone marrow in the form of myeloid hyperplasia, plus you need evidence of the Philadelphia positivity. Here is an example of a fish that is fluorescent in situ hybridization showing the BCR-ABL fusion. You can notice that the BCR probe is tagged in green and the ABL probe is tagged in red. And if you notice, in most of the cells there is a fusion of the red probe and the green probe, indicating that there is BCR-ABL fusion. That confirms Philadelphia positivity, and that's equal to diagnosis of CML in appropriate situations. Coming to the treatment of chronic myeloid leukemia. The current first-line treatment, or we can call it as a treatment of choice, is going to be the tyrosine kinase inhibitors. Most of the TKIs are going to bind to the active site, the ATP binding site of the abnormal dysregulated BCR-ABL fusion kinase, and thereby inhibiting the abnormal ABL kinase activity. In the past, people have been using hydroxyurea, but it is no longer considered to be a part of therapy in the first place in the setting of CML. So we are in the TK era right now, and we are going to use only tyrosine kinase inhibitors. And we have 3 generations of TKs. So first generation, second generation, and third generation. First generation TKI means only imatinib, which is also called as STI-571. There's a other name for imatinib. So imatinib is basically the first tyrosine kinase inhibitor against BCR-ABL fusion kinase. It's the first tyrosine kinase inhibitor. So it was in the pipeline since 1992, but it was available in the market only by around 1997-98. And it completely changed the face of oncology. It's one of the first targeted therapies for a cancer. That's why it completely changed the face of entire oncology. And it still remains the gold standard. The brand name for imatinib, the traditional brand that we use, is Gleevec. And we have some newer generation TKs also, like for example nilotinib and dasatinib, which are basically second generation TKs, and we have the third generation TKs, that is bosutinib and ponatinib. And when you can start second generation TK upfront, whenever the patient is having intermediate to high risk, especially as per the SOCAL index, if the patient is belonging to intermediate to high risk, you can skip imatinib and straight away start with the second generation TKI. And all of the newer TKs are approved for resistant disease. In case if patient is not responding very well to imatinib, then definitely you can start using the newer generation TK, the second or third generation. So there is a lethal mutation, a very important mutation called as T315I mutation. For this mutation, only ponatinib will be effective, and this can be asked in exams. Treatment of choice for T315I mutation is ponatinib. No other TKs work for this lethal mutation. So the treatment algorithm is going to go like this. First, you have to look at something called as SOCAL index. So If you're belonging to low risk in the SOCAL index, you can start with imatinib, no harm, straight away. In case if you're gonna have a poor response or a suboptimal response to imatinib, you can shift over to newer generation tyrosine kinase inhibitors like second or third generation TKIs. But remember, before switching over, always check for the mutation. If the patient is having T315I mutation, the only drug that we can use is ponatinib. It's a very important question for exam. The only drug I can use is ponatinib if the patient is having the lethal T315I mutation. On the other hand, if the SOCAL index is intermediate to high risk, then I can straight away start with newer TKIs, but still don't forget that for T315 it's only ponatinib, nothing more. So this is how the treatment algorithm goes in a nutshell. So let us talk about the side effects of the tyrosine kinase inhibitors. First, imatinib. So imatinib is a drug that's metabolized by both kidneys as well as by the liver. So all TKIs are associated with hematological toxicity, non-hematological toxicity, and there are some emerging toxicities according to the post-marketing data. Imatinib is the one that has the longest track record for safety. It's a very safe drug, but it can produce some minor side effects. It doesn't produce that much of hematological toxicity. It's intermediate. And to be honest, the most important side effect according to textbooks is going to be the edema. So like 30-40% patients can develop edema, but again, this is not a kind of toxicity role, and most of the patients are going to tolerate this edema very, very well. And patients tend to have GI side effects, and they can hypophosphatemia also, but these are not very important side effects. And emerging data says that patients can develop late renal effects and probably even heart failure. But this is not something that is clearly proved in the research. And what about nilotinib? Nilotinib and dasatinib are basically second generation TKIs, and both of these drugs are typically metabolized by the liver, and that's the reason why nilotinib especially can result in hyperbilirubinemia, and it can produce non-specific elevations in lipase. It can result in elevated cholesterol and can cause worsening control in patients who are having diabetes. So glucose also can be elevated. And it's the drug that has the least hematological toxicity that can be asked in exams. So in patients with severe hematological disease, nilotinib can be used as a choice. But the most important side effect that examiners are going to target is the fact that nilotinib can cause prolongation of the QT interval. And nilotinib, even though it's associated with vascular events, according to the latest data, to be honest, when you talk about vascular events and the tyrosine kinase inhibitor used in CML, it's almost always ponatinib. Ponatinib is more important in terms of vascular events. What about dasatinib? Dasatinib, the most important side effect is going to be the effusions. In fact, most of the patients tend to develop even a large pleural effusion. Very, very important side effect. When I talk about dasatinib side effect, it's almost always pleural effusion. That's a very important point. And among all tyrosine kinase inhibitors, dasatinib is the one that has the most severe hematological toxicity, and it can produce an aspirin-like effect. Dasatinib and ponatinib, these are the two drugs that tend to produce an aspirin-like effect. It can also prolong QT interval, but when it comes to QT prolongation, nilotinib is more important, and dasatinib can be associated with pulmonary artery hypertension according to emerging data, but the significance of the data is not clearly known. Coming to third generation TKIs, bosutinib is metabolized by the kidneys and ponatinib is metabolized by the liver. Bosutinib has intermediate hematological toxicity, and ponatinib also has intermediate hematologic toxicity, and ponatinib also has an aspirin-like effect. And bosutinib can cause gastrointestinal side effects and non-specific transaminitis. And emerging data says it can produce some mild late renal effects. But overall, to be honest, the safest TKI are going to be bosutinib and imatinib. These two are kind of very safe TKIs. You don't have that much of toxicity at all. Ponatinib can produce a non-specific elevation of lipase, and it can produce a frank pancreatitis also. And patients can develop rash and hypertension. It has been associated with heart failure and hepatotoxicity. And in the latest trials, there have been like strong data with regards to ponatinib and risk of vascular events. It can produce arterial thrombosis, venous thromboembolism, and it can produce a lot of hepatotoxicity also. So when I talk about vascular events, especially thrombotic manifestations or thromboembolic manifestations, in exam always answer ponatinib. So when it comes to imatinib, don't forget edema, nilotinib, QT prolongation, dasatinib, effusions, ponatinib, vascular events, especially thrombosis and thromboembolic manifestations. That's it. Very important for exams. Coming to assessing the response to therapy in CML and looking at some of the milestones, you can assess the response. So response can be assessed with the help of the QRT-PCR. So by looking at the BCR-able mRNA transcripts, so this is the thing that is usually done during follow-up. As I said, like qPCR is something that can be done with the help of peripheral blood sample itself. It's very, very sensitive. That's why this is better for follow-up rather than diagnosis. So, and you're going to have some optimal milestones that have to be achieved. So whenever you're going to look at the PCR for BCR-able mRNA transcripts, that is basically called as a molecular response. So if you use PCR, you're looking at something called as molecular response. Look at FISH, that's called as cytogenetic response. If you look at the peripheral blood, that's called as hematological response. So what do you mean by optimal response in PCR? So at 3 months, the amount of BCR-able transcript should be less than 10%, or we can say 1 log reduction should be achieved. And at the end of 6 months, the BCR-able mRNA transcript level should be less than 1%, or we can say 2 log reduction from the baseline. At 12 months and at any time, the proportion of BCR-able mRNA transcript should be less than 0.1%, which means 3 log reduction. So that is optimal at 3, 6 and 12 months. So what do you mean by suboptimal response? So either it could be a warning or it could be a frank failure of therapy. So when you call it as warning, at 3 months if the BCR-able mRNA transcripts are more than 10%, or at 6 months if the BCR-able mRNA transcripts are more than 1 to 10%, or at 12 months if the BCR-able mRNA transcripts are more than 0.1 to 1%, or loss of the major molecular response at any time will be regarded as a warning. So remember, if you're going to have a BCR-able mRNA transcript of less than 0.1%, that is 3 log reduction, it is also referred to as major molecular response, MMOR. So loss of MMOR at any time is regarded as a warning. What do you mean by failure? At 3 and 6 months, if the BCR-able mRNA transcript level is more than 10%, and at 12 months or at any time if the BCR-able mRNA transcripts become more than 1%, you're going to call it as a failure of therapy. So you have to consider newer TKs in that regards. So what are the other optimal milestones that you can try and achieve? Or we can say that you have to achieve. So first is complete hematological response. This should be achieved at 3 months. What do you mean by a complete hematological response? Platelet count should become normal. Usually most of the patients in chronic phase at the time of starting therapy, they're going to have thrombocytosis. So they should have a normal platelet count of less than 450,000. And they should have a normal spleen size. The splenomegaly should disappear. And the patient's WBC count should become normal, ideally less than 10,000 with normal differential count. And there will be slight basophilia in most patients with CML, that's acceptable. But the basophil count and the differential count should be less than 5% though, if you want to call it as a complete hematological response. And this should be achieved at 3 months. If you're going to use FISH, that's called as cytogenetic response. There are 2 types of cytogenetic response. One is called as partial cytogenetic response, or we can call it as complete cytogenetic response. What is the definitions for that? So if the proportion of Philadelphia chromosome is less than 35%, it's called as partial cytogenetic response, and optimally we should achieve that by 3 months. If the patient is reaching a Philadelphia chromosome level of 0%, which means undetectable Philadelphia chromosome, that's called as complete cytogenetic response, and they should be achieved at least 6 months. So what are the optimal milestones? Major molecular response at 12 months, a complete cytogenetic response at 6 months, and a complete hematological response at 3 months. These 3 are very, very important milestones. Let me repeat: complete hematological response at 3 months, complete cytogenetic response at 6 months, and major molecular response at 12 months. In case if the patient has encountered a failure of therapy, I told you the definitions of failure when it comes to RT-PCR. You have to change therapy, or even you can consider allogenic hematopoietic stem cell transplantation depending on the risk. In case if the patient is having only warning signs, not a defined failure, in that case you can consider either changing therapy or you can do a close monitoring, more frequent monitoring, even that is fine. So one can definitely repeat bone marrow aspiration to look for clonal evolution, and you also have to check for new acquired mutations in the BCR-able gene that can diminish the response over a period of time. If the patient has encountered a blast crisis, as we all know, it could be a myeloid blast crisis or a lymphoid blast crisis. If it's a myeloid blast crisis, then you can consider tyrosine kinase inhibitor therapy alone, in case if it's a newly diagnosed myeloid crisis for the first time. or if the patient is already on TKA developing a myeloid blast crisis, then you have to definitely consider combination of chemotherapy, standard AML-like therapy, plus you have to add a tyrosine kinase inhibitor on top of it as well. In case if you are dealing with a lymphoid blast crisis, the treatment will be very similar to that of ALL. That is something that we'll be discussing in the leukemia section. But when it comes to lymphoid crisis due to CML, and if you are using chemotherapy for that, try to use a low intensity chemo because the treatment related mortality is quite higher. Of course, we are going to add a tyrosine kinase inhibitor without a doubt because it's a CML related lymphoid crisis, that is CML related ALL like picture. After initial therapy, if the patient is fit for stem cell transplantation, almost all the patients should be taken up for allogenic hematopoietic stem cell transplantation because the moment patient develops blast crisis, that itself is an indicator of very poor prognosis. So in any high risk patient or patient with poor prognosis, the best hematological treatment that you can give is allogenic hematopoietic stem cell transplantation. That's why after this initial therapy, it's better to consider allogenic hematopoietic stem cell transplantation provided the patient is fit for the procedure. In case if the patient is pregnant, what are you gonna do? So remember, either you have to terminate pregnancy, that's very, very important, or you have to treat with interferons only. But interferons are not effective at all. They are very, very inferior compared to tyrosine kinase inhibitors. So why you can't use tyrosine kinase inhibitors? Because all TKs are contraindicated in the setting of pregnancy because they are teratogenic, and hydroxyurea definitely like something that should not be used in pregnancy. So if the patient gets pregnant, so definitely you have to consider treatment only with interferons. You cannot do anything else. You cannot use hydroxyurea and you cannot use any of the tyrosine kinase inhibitors as well. Now let us have a look at other important myeloproliferative neoplasms apart from CML. In that the most important for exams is going to be polycythemia vera. And by definition, polycythemia means increase in RBC mass. Remember, it's not just increase in the RBC number, it's increase in RBC mass. And this should happen without any physiological stimulus. Then only you can call it as primary polycythemia or polycythemia vera. And to be honest, even though in the peripheral blood, the most important finding is increase in RBC mass, it's going to result in high hemoglobin. Patients with polycythemia tend to have hyperplasia of all the elements in the bone marrow. There will be myeloid hyperplasia, erythroid hyperplasia, as well as megakaryoid hyperplasia. So that's often referred to as tri-lineage hyperplasia, or otherwise you call it as panmyelosis. So patients are going to have plus or minus increase in granulocytes as well as platelets in the peripheral blood. So it's not just about increase in the RBC mass. So that panmyelosis is characteristic of polycythemia. And the median age at the time of presentation of most cases of polycythemia is approximately 60 years, which means most of the patients will be old, but it's important to understand that 1/3 of the patients can be younger, where polycythemia vera can occur at the age of less than 50 years. And what are the most important clinical manifestations? Remember, most of the clinical manifestations are common between both polycythemia vera as well as essential thrombocytosis. In that, one of the most important and characteristic clinical manifestation is going to be the vasomotor symptoms. When it comes to vasomotor symptoms, the most important is erythromelalgia. So what is erythromelalgia? Patients are going to have intense burning sensation in the hands and feet that is associated with redness also. Erythema, redness, and intense burning sensation in the hands and feet. That is erythromelalgia, often one of the most prominent vasomotor symptom in the setting of polycythemia vera and essential thrombocytosis. And some patients can develop a peculiar condition called as aquagenic pruritus, which is nothing but severe itching that develops after taking a hot shower. And that is because the mast cells in the setting of polycythemia and essential thrombocytosis may be abnormal and they degranulate upon hot shower. So that's why you're going to result in pruritus. And if the cell turnover is very high, it can result in B symptoms because the tumor burden itself, like loss of weight, loss of appetite, and low-grade fever and so on. And because of the high cell turnover, again, patients can develop hyperuricemia and gout-like features. And patients also tend to develop hyperviscosity features. This can again be seen in both essential thrombocytosis and polycythemia vera, but it's common in polycythemia than essential thrombocytosis. And that is because of the sluggish blood flow, because of hyperviscosity. So if the blood flow is sluggish in the brain, in the CNS, you're going to result in headache and dizziness. It can also result in tinnitus. If the blood flow is sluggish in the retinal vasculature, it's going to result in blurred vision. And this hyperviscosity itself is a risk factor for development of thromboembolic manifestations. But the most important risk factor for thromboembolic manifestation in the setting of polycythemia vera and essential thrombocytosis is increase in the WBCs. It's interesting because people think that increase in the platelets are the ones that are going to correlate with thromboembolic manifestations, but it's not. It's the increase in WBCs that often tends to correlate with thromboembolic manifestations in both polycythemia vera and essential thrombocytosis. And again, interestingly, thrombosis can be either arterial as well as venous. This is one of the unique conditions where you're going to result in both arterial as well as venous thrombosis. Remember, conditions like factor V Leiden mutation, antithrombin 3 deficiency, protein C deficiency, protein S deficiency are all going to produce predominantly venous thromboembolism. But this is one such example, one such condition which can result in both arterial as well as venous thrombosis. And again, another interesting point is the fact that bleeding is going to correlate with high platelet count. Especially the platelet count is more than 1 million, then the bleeding risk is actually quite high. And people may think like low platelet are the ones that are going to result in bleeding. No, in the setting of PV and essential thrombocytosis, it's the high platelet, more than 1 million, that's going to be associated bleeding. And this is probably due to abnormal platelet function. Of course, this is a kind of a tumor. Even there is increased proliferation of all the lineages, the platelet function will be as such abnormal, and these tumor cells can adsorb the von Willebrand factor on its surface, resulting in a kind of acquired von Willebrand disease. And that can also be the reason for bleeding. And what are the important signs? Splenomegaly can be there, but remember, only in CML and in primary myelofibrosis you're going to have a moderate to massive splenomegaly, but in the setting of polycythemia vera and essential thrombocytosis, you're going to have only a mild splenomegaly, very important point. And because of hyperviscosity, patients can develop hypertension as well. Coming to the molecular analysis, what are the mutations that you see in the setting of myeloproliferative neoplasms apart from CML? The most important, the most common mutation in any myeloproliferative neoplasm apart from CML is going to be the JAK2 V617F mutation. Very important point. JAK2 V617F mutation, that's seen in 95% of the patients. In approximately 4% of the patients, you're going to see JAK2 mutations only, but the mutation will be in the exon 12 area, that's called exon 12 deletion. And very, very rarely in polycythemia vera, the mutation can be affecting the link gene or SOCS gene. Very rarely, less than 1% cases. But the most important is JAK2 mutation, typically the V617F mutation. And if they ask you the most common cytogenetic abnormality in the setting of polycythemia vera, it is 20q deletion, most common cytogenetic abnormality. So what is the WHO diagnostic criteria for polycythemia vera? So you have some major manifestations, you have some minor manifestations. If you have 3 major or first 2 major along with 1 minor manifestation, you can make a diagnosis of polycythemia vera. The first 3 are basically major manifestations, and the last one is basically the minor manifestations. Low EPO is a minor manifestation. So first you should have evidence of increased red cell mass, which means high hemoglobin. So in males, it is defined as a hemoglobin of more than 16.5 grams per deciliter or a hematocrit of more than 49%. And in females, the hemoglobin is more than 16 grams per deciliter, and or if the hematocrit is more than 48%, you can call it as high RBC mass. Number 2, I said in the bone marrow aspiration or biopsy, you should have hypercellularity with trilineage hyperplasia, often referred to as panmyelosis. Very, very important point with regards to polycythemia vera. And of course, the third major criteria, presence of JAK2 mutations, any JAK2 mutation, either V617F or exon 12 mutations. Minor criteria is reduced serum erythropoietin, which means what I'm trying to prove is increased RBC mass is occurring without any physiological stimulus. If it's a physiologically mediated increased RBC mass, the erythropoietin level should be high. But here it will be suppressed because it's a primary polycythemia. And what about the prognosis? The most common sequelae of polycythemia vera is thromboembolic manifestations. Very important point. What are the risk factors for thromboembolism? Elderly patients, age more than 60. Number 2, history of thrombosis. Number 3, high WBCs like more than 15,000. Number 4, smoking. These are the 4 important risk factors for thromboembolic manifestation in the setting of polycythemia vera. The median survival in patients with polycythemia vera is approximately 14 years. If it's a younger population, like less than 50 years at the time of diagnosis, the average survival is approximately around 24-25 years. So it's a decent survival, to be honest, for a tumor. And some patients can end up with myelofibrosis, even though this is not very common in the setting of polycythemia vera. That's called as spent phase. So the risk of developing myelofibrosis is 10 to 20% at 20 years. And because it's a myeloid problem, patients can end up with some myeloid malignancies like acute myeloid leukemia. Some patients can develop MDS also, but that's rare. But rather, most of the patients, if at all they develop a cancer, it's going to be acute myeloid leukemia, and the risk is quite low, less than 10% at 20 years. So that's it with regards to polycythemia vera and its clinical presentation. Now let us talk about the treatment of polycythemia vera. Every single patient with polycythemia is going to definitely receive aspirin because the most common sequelae of polycythemia is thromboembolic manifestations. Of course, to reduce the RBC mass, we need to consider phlebotomy as well. And in case if the patient is having hyperuricemia, you can try allopurinol to reduce the uric acid. And in case the patient is having aquagenic pruritus, you can try antihistaminics also, because the reason for aquagenic pruritus is increased histamine release from the mast cells. These are abnormal mast cells, we discussed already. And what is the target for phlebotomy? We have to look at the hematocrit. For males, the target hematocrit is less than 45%. For females, the target hematocrit is less than 42%. In case if you are dealing with a pregnant female, the target hematocrit will be less than 37%. And in case if the patient is belonging to high risk group, what do you mean by high risk? Elderly patients, age more than 60, or in those with history of thrombosis, it's better to add cytoreductive therapy. The first line cytoreductive treatment in the setting of polycythemia vera even now is hydroxyurea, simply called as Hydrea. So what are the important indications for hydroxyurea? Number one, if the patient is belonging to high risk group like age more than 60 or history of thrombosis, you can add hydroxyurea. If the patient is having raised hematocrit that is not able to be controlled with phlebotomy, you can use hydroxyurea. Or if the patient is having symptomatic large splenomegaly, this is very rare, it occurs in polycythemia, yes, you can start with hydroxyurea in that case. Or if the platelet count is more than 1.5 million, very high platelet count, that's going to increase the risk of bleeding like anything. So these are the usual indications of initiating hydroxyurea. What are the important side effects of hydroxyurea? The most common side effect is skin ulceration or oral ulceration. This is the most common side effect, and some patients can develop myelosuppression as well. In case if the patient is not tolerating hydroxyurea better, or if the patient is not achieving a good response to hydroxyurea, you can add a non-selective JAK1/2 inhibitor that's called as ruxolitinib. So because the most common mutation is JAK2 mutation, you can try a JAK inhibitor like ruxolitinib. But it's kind of non-selective JAK inhibitor. It works on both JAK1 as well as JAK2 receptor. Remember, tofacitinib acts on JAK1, 2, 3, ruxolitinib on JAK1, 2, upadacitinib only on JAK1. But only ruxolitinib can be used for the setting of myeloproliferative neoplasms among the three drugs, that is tofacitinib, baricitinib, ruxolitinib, and your upadacitinib. Other three drugs, tofacitinib, baricitinib, and upadacitinib, will be used in rheumatological disorders like rheumatoid arthritis. In case if the patient is pregnant, you cannot use hydroxyurea. Hydroxyurea is contraindicated in pregnancy. You cannot use ruxolitinib. It's also contraindicated in pregnancy. The only way out is interferons, like what we have discussed in CML. But interferons are contraindicated in thyroid disorders, especially hypothyroidism, and in patients who are depressed. And remember, one study that was done with regards to efficacy of different agents proved that interferons is the only agent that is shown to decrease JAK2 levels. Even if you use hydroxyurea, tyrosine kinase inhibitors, it doesn't matter, JAK2 levels doesn't come down. So interferons are the only agents that are associated with reduced JAK2 levels, even though we don't use it commonly. And because of that, we can say that interferons are the only drugs that when it's used is associated with the possibility of remission. No other drug is going to be associated with possibility of remission except interferons. That's an interesting point. Coming to essential thrombocytosis. So what is essential thrombocytosis? As the name implies, the platelet counts are going to be higher in the peripheral blood. There's going to be megakaryoid hyperplasia in the bone marrow. You're not going to have panmyelosis, rather megakaryoid hyperplasia in the bone marrow with abnormal megakaryocytes in the bone marrow. Along with that, in the peripheral blood, you're going to see more and more platelets. So it's a clonal hematopoietic disorder. It's a myeloproliferative neoplasm that is going to result in increase in the number of platelets. Typically, the platelet count is going to be more than 450,000. And like polycythemia, where the median age at the time of presentation is 60 years, but 1/5, around 20% of patients can present at a younger age, less than 40 years. In polycythemia, 1/3 of the patients tend to present at age less than 50, but in essential thrombocytosis, 1/5, 20% of patients tend to present at a younger age, less than 40 years. What are the clinical manifestations? Most of the clinical manifestations are going to be very, very similar to that of polycythemia vera, which means patients can develop vasomotor symptoms like erythromelalgia. There is a risk of thrombosis, there is a risk of bleeding, and patients can develop aquagenic pruritus, and patients can develop almost all the clinical manifestations like polycythemia vera. When it comes to the molecular studies, again the JAK2 mutations are going to be the commonest. The V617F mutation, that's the commonest. but it's seen only in 50 to 60% as opposed to polycythemia where JAK2 V617 of mutation is seen in approximately 95% plus patients. And the second most common mutation is going to be the CALR exon 9 mutation that is seen in approximately 1/4 of the patients, 20 to 25%. And the least common mutation is the MPL or CMPL mutations, typically the exon 10 mutation that is seen in 5 to 10% cases. And approximately 10 to 15% of the cases can be triple negative. This is another very important point. So you may not see any of the mutations like JAK2 or CMPL or CALR mutations. Coming to cytogenetics, the usual cytogenic changes that are associated with essential thrombocytosis will be trisomy 8-9, 13q deletion and or 20q deletion. So how about the diagnostic criteria? We have WHO diagnostic criteria here as well. So criteria number 1, patient should have sustained thrombocytosis. Platelet count should be more than 450,000 without any obvious cause. You have to rule out all the other secondary possibilities. That's very important. So bone marrow aspiration will be showing increase in the number of mature but abnormal megakaryocytes. Very, very important. Mature but abnormal megakaryocytes. There will be a lot of megakaryocyte abnormality in the setting of essential thrombocytosis. Plus, you should not have any left shift to rule out CML. Plus, you should not have increase in the erythroid precursors to rule out your polycythemia vera, because in polycythemia vera also there could be increase in the number of megakaryocytes in the bone marrow because of pan-myelosis. That's why to rule out polycythemia, you have to prove that the patient is not having increase in the erythroid precursors. There's no erythroid hyperplasia. Plus, at the same time, there should not be any left shift and increase in the number of your myeloid precursors to rule out CML. And to be honest, the left shift is the one that's going to be more important in the setting of essential thrombocytosis, because there could be slight granulocyte hyperplasia in the bone marrow, but apart from that, you should not have any absolute left shift in the bone marrow or probably in the peripheral blood. And patients should not meet criteria for the diagnosis of polycythemia vera, primary myelofibrosis, CML, MDS, and other myeloid neoplasms. So technically, we can say that essential thrombocytosis is a diagnosis of exclusion. And patients should have some acquired mutation of a clonal marker. This is one criteria. It may not be there because patient may be triple negative, but one mutation generally will be there, like most commonly JAK2 or CALR or CMPL. Or one can also prove that the patient is not having any reactive thrombocytosis. You have to prove the absence of any causes of reactive thrombocytosis. That's very important. That's an alternative. So you can divide thrombocytosis into reactive thrombocytosis, thrombocytosis due to MDS and other myeloproliferative neoplasms, which are nothing but primary thrombocytosis. Reactive is also called as secondary thrombocytosis. What are the usual causes? Iron deficiency anemia. Very, very important cause. That's why at the time of bone marrow aspiration itself, it's better that you do iron staining with the help of pulse Prussian blue and prove that the bone marrow iron stores are adequate in the setting of diagnosis of essential thrombocytosis, because you have to rule out iron deficiency anemia. And second is infection. Third is inflammation. Then malignancy can produce reactive thrombocytosis. Acute bleeding can result in reactive thrombocytosis. And because spleen sequesters a lot of blood cells, including RBCs and the platelets, after splenectomy, you can notice reactive thrombocytosis. And next, we have something called MDS, myelodysplastic syndrome, especially the RAS-T type, that is refractory anemia with ring sideroblasts of thrombocytosis type. So that is a kind of MDS MPN overlap. We'll talk about that. That can also produce severe thrombocytosis. And some cases of your isolated 5q deletion also can be associated with reactive thrombocytosis due to MDS. And there are a lot of other myeloproliferative neoplasms we know already, like polycythemia vera, myelofibrosis, as well as pre-PMF along with essential thrombocytosis can result in thrombocytosis. These are primary case of thrombocytosis, not reactive. So what's going to be the treatment? So in case the patient is having vasomotor symptoms, the most important treatment is going to be aspirin. But you have to be a little careful in patients with very high platelet count, like more than 1 million, because these patients are inherently associated with high bleeding risk. But if you add aspirin on top of that, the bleeding risk is going to increase substantially. If the patient is belonging to high risk category, what do you mean by high risk? The two constant parameters, age more than 60, history of thrombosis, and or if the patient is having a platelet count of 1.5 million, then you have to consider adding cytoreductive therapy with the help of hydroxyurea. That's the first line treatment. In case if patient is not tolerating hydroxyurea, then an alternative will be anagrelide, which is a phosphodiesterase inhibitor. But this is inferior to hydroxyurea. Very, very important point. Anagrelide is a phosphodiesterase inhibitor, but inferior to hydroxyurea. You have to add only if the patient is not tolerating hydroxyurea. In case if the patient is young and desiring pregnancy, or if the patient is already pregnant, then the choice will be interferons. hydroxyurea cannot be used in that setting. And what is the risk of primary myelofibrosis? In the first decade of the disease, it's 3 to 10%, and in the second decade of the disease, it is 6 to 30%. So it increases over time. And the overall risk of acute myeloid leukemia transformation is quite low at less than 2%. So that's not a big concern. Coming to primary myelofibrosis. So what's the definition? So it's a clonal hematopoietic disorder with reactive bone marrow fibrosis. That is the most important problem here. So bone marrow cellularity can be like quite variable. It can be hypercellular, especially if it's pre-PMR, or it can be like normocellular, or over time it can become hypocellular because of the replacement of the hematopoietic elements with fibrotic tissue. Plus, most of the patients show evidence of extramedullary hematopoiesis. Because of severe fibrosis of the bone marrow, you don't have space for the normal hematopoiesis to occur in the bone marrow. Because of that, your other organs like liver and spleen has to take over, and that's what we call it as extramedullary hematopoiesis. That's quite common. That's the reason why most of these patients tend to have hepatosplenomegaly. And because of the infiltration of the bone marrow by fibrotic elements, and you don't have space for the normal hematopoiesis to occur, you're going to have a characteristic myelophthisic picture in the peripheral blood. We'll talk about that. And the median age is again 60 years, like most cases of myeloproliferative neoplasms, but very few patients can have myelofibrosis at a younger age, but that's not very common. And what is the etiology of myelofibrosis? So various myeloproliferative neoplasms can result in myelofibrosis. If it occurs at the time of diagnosis itself, then it's called as primary myelofibrosis, or if the patient is a known case of polycythemia vera or essential thrombocytosis developing myelofibrosis. It was also once upon a time called as primary myelofibrosis, but currently it's called as post polycythemia vera or essential thrombocytosis related myelofibrosis. And certain cancers can induce myelofibrosis, like hematological cancers and certain solid organ tumors. And various autoimmune disorders like SLE also can rarely result in myelofibrosis. Certain toxins like benzene can result in myelofibrosis. Granulomatous infiltration of the bone marrow over a period of time can result in myelofibrosis. Certain deposition disease like amyloidosis or probably Gaucher's disease can also result in the development of myelofibrosis. But we are going to stick on to the primary myelofibrosis in this chapter, nothing more. So what are the mutations that are associated with primary myelofibrosis? The most common mutation once again is the JAK2 V617F mutation, seen in approximately 50% of the cases. The exon 12 mutations can be seen in 15% of the patients. Second most common is CALR mutation, seen in 25%, and the third most common is CMPL mutation, seen in 10%. But it has to be remembered that up to 5 to 10% of the cases can be triple negative, which means none of the mutations can be seen. And textbooks also mention that overall survival is going to increase with CALR mutation. So presence of CALR mutations is a sign of better prognosis in patients with primary myelofibrosis. And patients can get transformed into acute myeloid leukemia, and the risk is going to be higher with certain mutations like ASXL1, SRSF2, and IDH1/2 mutation. These are MDS related mutations, right? So if these are there, there is a higher risk of getting converted to acute myeloid leukemia, and some patients can get transformed into myeloid dysplastic syndrome as well. What are the clinical features? The most important clinical feature is cytopenia, and the most common cytopenia is anemia. Patients are going to complain of fatigue, and patients can have leukopenia, especially neutropenia, and patients can have thrombocytopenia as well, but it may or may not be there. But in most cases, anemia will be there. And remember, in patients with essential thrombocytosis and polycythemia vera, you don't really have anemia. Rather, patients can have normal hemoglobin in the setting of essential thrombocytosis, or increased hemoglobin in the setting of polycythemia vera or even essential thrombocytosis, but no anemia. Anemia is a feature of CML. We have discussed that already, but it can be seen in PMF also. WBC and platelet counts are highly variable, but over a period of time, because of replacement of the bone marrow with fibrotic elements, you can notice pancytopenia as well. Patients can have B symptoms also because of the tumor cell turnover, and patients can have massive hepatosplenomegaly. So most of the time, splenomegaly will be moderate to massive. This is something I told you already, and this is probably due to extramedullary hematopoiesis. And patients can develop thromboembolic manifestations as well, albeit lesser in frequency compared to that of your polycythemia vera and essential thrombocytosis. How we are going to arrive at a diagnosis? First, look at the peripheral smear. We are going to have the characteristic myelophthisic or leukoerythroblastic picture. We are going to have the characteristic triad. We are going to have the NRBCs, that is immature RBCs, and teardrop RBCs. These are also called as dacrocytes, and we are going to have increase in the number of immature WBCs like myelocytes, metamyelocytes, and promyelocytes. So that's what we call as a typical leukoerythroblastic picture. and patients are going to have large abnormal platelets. Remember, in essential thrombocytosis, you tend to have a stagon kind of a megakaryocyte, but here you have an abnormal bulbous megakaryocyte, And in bone marrow aspiration, you're going to notice a dry tap because of extensive bone marrow fibrosis. In that case, you have to proceed with bone marrow biopsy. So, in fact, one of the important indications of bone marrow biopsy is a dry tap. So if you look at the cytogenetics, there is no specific cytogenetic change with regards to your primary myelofibrosis. All you have to do is you have to prove that the patient is not having BCR-ABL1 fusion, which means the patient should be Philadelphia negative. That is to rule out CML. And patient should not have the disease that's going to fulfill the criteria for the diagnosis of polycythemia vera or essential thrombocytosis. That's a very important point as well. So look at this picture. So here is an example of essential thrombocytosis. We're going to have abnormal multilobated stagon type of megakaryocytes, and in the setting of your primary myelofibrosis, you're going to have abnormal bulbous kind of megakaryocytes, and in this case the number of megakaryocytes are actually quite low because of extensive fibrosis, which can be found out with the help of certain stains like Matson's trichome that stains collagen. But apart from that, in both these cases of essential thrombocytosis as well as primary myelofibrosis, the megakaryocytes are looking abnormal. They're grossly abnormal. So coming to the prognosis, there is a separate IPSS score for assessing the prognosis of myelofibrosis. You have 5 important variables. One is the constitutional symptoms. Second is elderly patients age more than 65. Third is presence of cytopenia, especially anemia, hemoglobin of less than 10 grams per deciliter. Number 4, leukocytosis with the WBC of more than 25,000. And number 5, peripheral blood blast count. If it's more than or equal to 1%, it indicates high risk. So 5 variables, each gets 1 point. So the score is going to range from 0 to 5. If the score is 0, it's low risk, 1 to 2, intermediate risk, and 3 to 5, it's high risk. So currently we use the revised scoring system called as DIPS scoring. So where additionally we are going to add cytogenetic elements also. So if the patient is having additional trisomy 8, monosomy 7 or 7q deletion, monosomy 5 or 5q deletion, 12p deletion, inversion 3 or 11q23 MLL rearrangements. So these are considered to be high risk cytogenetics, and in this case the risk of transformation to AML is going to be quite higher. Or if the patient is having complex cytogenetic abnormalities like 3 or more than 3 chromosomal abnormalities, then that is also a very high risk feature. And apart from the cytogenetics, the DIP system also makes use of the transfusion requirements. If they require more transfusions, the risk is quite high, and they make use of the thrombocytopenia as well, which if it's present, it indicates severe replacement of marrow elements by fibrosis, and that is the reason why that's a poor prognostic indicator as well. So the median survival with PMF is much lesser compared to other myeloproliferative neoplasms. It's in the order of around 6 years, and the risk of transformation to AML is also quite high at 8% per year. So remember, in case if the patient is asymptomatic or if the patient is not at high risk, which means the patient is not having cytopenias, then no need to treat this disease. You can just observe. If the patient is belonging to intermediate to high risk category, then the first line treatment according to most of the guidelines is ruxolitinib, which is shown to definitely reduce the amount of symptoms. It's shown to reduce the splenomegaly, and overall it's associated with increased survival. And you can also consider the use of newer tyrosine kinase inhibitors like momelotinib, pacritinib, and fedratinib. This can be asked in exam because these 3 drugs are exclusively approved for primary myelofibrosis only. What are the 3 drugs? Momelotinib, pacritinib, and fedratinib. And if the patient is young, it's very rare to have a young patient with primary myelofibrosis. In case if the patient is supposedly young, like less than 50 years or 40 years, then you can definitely consider allogeneic hematopoietic stem cell transplantation if the patient is belonging to high risk category. And apart from that, most of the patients' primary issue will be cytopenia, so you can support that with the help of PRBCs or erythroid stimulating agents like epoetin alpha, darbepoetin alpha, if the erythropoietin levels are less than 500. But the problem is this can worsen splenomegaly, very important point, because there is extramedullary hematopoiesis and the RBC precursors are developing in the spleen. In this case, if you give erythropoietin, that can get accelerated and that can worsen the splenomegaly. And one can definitely consider the use of androgens or probably a combination of lenalidomide with prednisolone in selected group of patients. And one can definitely even consider splenectomy in case if the patient is transfusion dependent. Very important indication of splenectomy in patients with PMF is transfusion dependency and or anemia that is refractory to standard therapy that you are using, or the patient is having painful or a symptomatic large spleen. So these are the three indications of splenectomy. Most important is transfusion dependency. And one can also try hydroxyurea if the WBC counts and or platelet counts are higher, especially the platelet count is more than 1 million or 1.5 million, you can try hydroxyurea, but hydroxyurea is not associated with improved survival. That's why we don't use it often in the setting of primary myelofibrosis. So look at this image. So this is a typical image of a patient who is suffering from primary myelofibrosis. This is a kind of a reticulin stain. You can notice how severe the fibrosis is, and you can also notice the abnormal bulbous looking megakaryocytes. So this is an image of primary myelofibrosis, by the way. Now coming to other myeloproliferative neoplasms. In that, in exams, they might ask about something called as mastocytosis. Mastocytosis is of two types. One is called as cutaneous mastocytosis. Second is called as systemic mastocytosis. And whatever may be the case, more than 90% of mastocytosis patients tend to have the characteristic KIT D816V mutations, which is something that I have described at the very beginning of the chapter itself. So cutaneous mastocytosis is going to present with skin lesions. And the characteristic skin lesion in the setting of cutaneous mastocytosis is going to be urticaria pigmentosa. Very, very important. Urticaria pigmentosa. So here is a look at a patient who's having urticaria pigmentosa, a very typical skin lesion that is seen in patients with any mastocytosis, let it be cutaneous or extra-cutaneous systemic mastocytosis with skin involvement. Plus or minus, patients have a tendency to develop frequent episodes of anaphylaxis because it's a disorder of mast cells, and they degranulate quite often even to simple triggers resulting in anaphylaxis. And diagnosis can be established by skin biopsy. You are going to see abnormal mast cells in those biopsy specimens. And interestingly, the bone marrow and serum tryptase will be normal. That's a very important point. Only in systemic mastocytosis, the serum tryptase will be abnormal and the bone marrow aspiration studies will be abnormal. But in cutaneous mastocytosis, bone marrow aspiration as well as serum tryptase levels will be normal. Coming to systemic mastocytosis, here the problem is organ infiltration by this abnormal cancerous mast cells. Plus or minus, of course, they can have skin involvement and urticaria pigmentosa. Plus or minus, they can have frequent episodes of anaphylaxis. Plus, more importantly, they'll have systemic features because of systemic involvement. Systemic mastocytosis can be either indolent or very aggressive, which can present with severe organ dysfunction. And diagnosis will be done with either bone marrow aspiration or tissue biopsy. So what are you going to see in the bone marrow aspiration and or tissue biopsy? You're going to see multifocal atypical mast cell aggregates. Remember, these are not usual mast cells, these are atypical mast cells, and by definition, at least 25% mast cells should be atypical for making a diagnosis of systemic mastocytosis. In case if we see a lot of abnormal atypical mast cells in the peripheral blood, in the bone marrow or in the peripheral blood, it will be called as mast cell leukemia. If more than 20% of atypical mast cells are infiltrating the bone marrow and are circulating the peripheral blood, it will be called as mast cell leukemia. Another very important point. As I said, if you are dealing with a systemic mastocytosis, the serum tryptase definitely will be elevated. And of course, you're going to have abnormal bone marrow. We discussed that already. And these mast cells are going to be positive for CD2 and CD25. And because of that, in the blood also CD2 and CD25 will be positive. These are considered as kind of tumor markers for systemic mastocytosis. Treatment supportive with antihistaminics just to prevent anaphylaxis, and you can try the KIT inhibitors, KIT tyrosine kinase inhibitors like midostaurin or avapritinib. These are the approved therapies for cutaneous and systemic mastocytosis, but imatinib is not effective for this kind of KIT mutations. So imatinib is not effective for the D816V kind of KIT mutations. You have to use only midostaurin or avapritinib. Coming to other myeloproliferative neoplasms, we have a myeloproliferative variant of hypereosinophilic syndrome. So what do you mean by MPN variant of HS? The patients are going to have clonal eosinophilia. Very important point. Patients are going to have clonal eosinophilia with eosinophil count more than 1500, which means the absolute eosinophil count will be more than 1500, severe eosinophilia. Plus, you should not have any secondary cause. Remember, if you only have severe eosinophilia without any secondary cause, and if you don't have clonality, that's hypereosinophilic syndrome. Because you have clonality here, it's basically a malignant condition. It's a myeloproliferative variant of hypereosinophilic syndrome. So because of severe eosinophilia, you know that these are abnormal eosinophils. They're going to cause eosinophilic infiltration of multiple organs, resulting in multi-organ involvement. And in any hypereosinophilic state, the heart and the lungs are the ones that are going to be prominently affected. Cardiac involvement is very common, and this is the usual reason for death as well. And apart from that, patients can have GI, skin, as well as liver involvement, causing colitis, hepatitis, and so on. And the usual genetic problem that's associated with this condition is abnormalities in the PDGFR-A gene. So PDGF receptor alpha is going to get rearranged itself with FIP1L1 because of a deletion of a region called as 4q12 in the chromosome 4. The FIP1L1, which is present in chromosome 4, and PDGF receptor A gene that is present in chromosome 4 is going to come together and fuse with itself. Both are actually present in chromosome 4 only. And apart from that, it can involve fusion of PDGF receptor B, FGF receptor 1, or the fusion can be in the form of PCM1 JAK2 also, which is something that I discussed already at the very beginning of the chapter. Most of the cases are going to have cytopenias, hepatosplenomegaly, and interestingly, they will have high serum vitamin B12, and there will be increase in the number of blasts, but it will be less than 20%. That rules out acute leukemia. So treatment is imatinib. Remember, for this kind of rearrangement, so FIP1L1 PDGF receptor alpha fusion, so imatinib works, but it may not work for the PDGF receptor B, FGFR1, or probably PCM JAK2, but definitely for FIP1L1 PDGF receptor alpha fusion, 100% imatinib will work. Otherwise, you have to use corticosteroids and cytoreductive therapy. This is going to be the final slide, where we're going to talk about disorders that are associated with kind of MDS as well as MPN-like picture. We have 4 disorders: atypical CML, CMML, that is chronic myelomonocytic leukemia, MDS MPN with ring sideroblasts, and we have JMML, that is juvenile myelomonocytic leukemia. It's important to note that before diagnosing any of these disorders, you have to rule out all the secondary causes. You have to rule out other myeloproliferative neoplasms also. Basically, these are very rare disorders and diagnosed of exclusion, by the way. And because it's a MDS MPN overlap, you're going to have features of MDS. In the sense, dysplasia will be seen in almost all the cases. And because it's not an acute leukemia, your amount of blast should be less than 20% in the bone marrow as well as in the peripheral blood. And there are some unique mutations that you have to remember for exams. If it's atypical CML, you have to remember the SETBP1 mutations. This is actually quite important, has been asked in exams, but other mutations are also there, but SETBP1 is the most important. So CMML patients tend to have mutations similar to MDS, and MDS MPN with ring sideroblasts tend to have the same JAK2 V617F mutations. And you have to definitely rule out other myeloproliferative neoplasms. That's why you need to look at some genetic abnormalities, and you have to prove that the patient is not having BCR-ABL1 fusion, because you have to rule out CML, and you have to rule out the MPN variant of hypereosinophilic syndrome also. That's why you have to rule out the PDGFR and FGFR rearrangements also. And as the name implies, atypical CML is going to look like CML. Of course, they are going to have dysplastic features without any BCR-ABL fusion, but the picture is going to be similar to that of CML. So they're going to have leukocytosis with prominent neutrophilic left shift. When it comes to CMML, the name itself says myelomonocytic leukemia. So that's the reason the most important diagnostic feature is presence of monocytes in the peripheral blood to a value of more than 1000 or more than 10% in the differential count. These monocytes of more than 1000 in the peripheral blood, very important diagnostic feature when it comes to exams especially. When you talk about the MDS MPN with ring sideroblasts, the most important feature is thrombocytosis. Patients are going to have a platelet count of more than 450,000, plus you should have more than 15% of ring sideroblasts in the bone marrow. Remember, I told you for a pure MDS, if the patient is having SF3B1 mutation, the cutoff is 5%, not 15%. But in an MDS MPN overlap like this, even in the presence of SF3B1 mutations, the cutoff for ring sideroblasts is 15%, not 5%. So clinically, how they're going to present, atypical CML patients are going to be elderly. In fact, almost all of these patients will be older, and patients will have cytopenias like anemia as well as thrombocytopenia, just like CML. And CMML patients can sometimes behave like the AML M4, M5 variants, which can present with gum hypertrophy, skin rash, and hepatosplenomegaly. And MDS MPN with ring sideroblast patients are going to present with anemia predominantly, as the name implies. What about JMML? That is juvenile myelomonocytic leukemia. So the age of presentation is the most important thing. So because it's called juvenile myelomonocytic leukemia, the age of presentation will be like lesser. Most of the patients are going to be younger, and most patients will be very young, like around 2 years of age. It's a pediatric disease. And like your CMML, you're going to have excessive monocytes in the peripheral blood. The value should be more than 1000 at least, or more than 10% the differential count. And the mutations here will be completely different. So when it comes to CMML, the mutations will be similar to that of MDS, right? But here the mutations will be different, like PTPN11 mutations, NF1 mutations, KRAS mutations, or NRAS mutations. And most of these patients will be having higher hemoglobin F, a very important point. And they're going to have a higher GM-CSF, or they can have GM-CSF hypersensitivity. This has been asked in one of the INSET exams. So GM-CSF hypersensitivity and higher levels of hemoglobin F. And or these patients also tend to have STAT5 hyperphosphorylation. This is a straight line from Harrison again. And most of the patients do have hepatosplenomegaly. And death in these patients is typically due to organ infiltration or probably infections because of these abnormal monocytes that are circulating. And with that, we are completing the entire myeloid disorders except for the AML. We'll be discussing that in acute leukemias. And with that, I'm signing off. Thank you very much.